So, Aswita, we've just been talking about reducing readmissions and looking at issues with an equity lens and all the components of that. How do you translate what's learned by stratifying for disparities in readmissions work? How do you translate what you're learning there into other clinical areas in healthcare? Are there lessons? Are there ways to apply what you're learning?
When I think about what you need to have in place in order to be able to do that, it's leadership buy-in, knowing that the data collection that you have within your system on race, ethnicity, and language data is reliable. You need to have the buy-in from the quality side, understanding that this is about quality of care, and so we have to look at quality measures. And you have to have the transparency with which an organization wants to address this. And so look at this data and then decide to do something about it. So monitoring and reporting and then developing an intervention. So when I think about all those components that we need in order to do this readmissions, it's very similar to just all the components we need in general to do this type of work when we focus on disparities. And just the ability to talk about we might be providing care differently to different populations, and it might be because of their race. And so just being able to have that conversation is what's necessary for an organization to really address disparities in general, but in particular to readmissions because it's tied to payment.